how patient preference impact treatment decisions. A fun fact of Dr. Lee is he is. You're still a big college football or okay? And oh, you're a fan of college football, and his favorite team is the Ohio State. How is that? Whoa. Okay. But he's looking forward to the various West Coast schools joining the Big Ten Conference, which allow him to attend more games on the West Coast when his team comes to play.
That's right.
Yeah. Welcome, Dr. Lee.
All right. Thanks, everyone. So you are taking time away from my football Saturday, but I'll always make that exception for you guys and everything, and honored to be here. So I'm gonna be talking about a slightly different topic, but I think it's a topic that's certainly very important to all of you in terms of how you navigate a lot of the treatment options that you just heard from either Dr. Ganji or Dr. Hendefar as well. So we're going to really discuss, patient preferences and in terms of how that really impact our treatment decisions. So as you've heard, patients with neuroendocrine tumors certainly have multiple treatment options, whether it's surgery, all the different various types of treatments that Dr. Hendefar just listed, a lot of different options, right? And we don't have necessarily any data in terms of how ultimately we sequence all of these treatments. So as a result of that, there's a lot of choices that we have to make. But with that, each treatment really has various different types of side effects. So a lot of times when I see you in my clinic, one of the questions that we kind of go over is, what are the different types of toxicities to each of the different treatments? Because I feel like that's definitely important to discuss. And really, how is that going to impact your life on a daily level? The stated goal for most of the treatments that have been covered either by Dr. Hendefar or by Dr. Del Villarreal is that when we do a lot of these clinical trials, the FDA, as well as discussions with investigators so far, have been that the stated goal for most treatments, what we have to show, is whether or not they can potentially increase survival, i.e., whether or not it can help you live with the cancer longer. But this really begs the question, but at what cost? What is the cost for us to control the cancer and allow someone to live longer in terms of what's the effect of the treatment on your daily life? So this really led us to kind of ask the question at our center and really take the initiative on this, because this was what I was hearing a lot from our patients. And the idea is, what do patients with neuroendocrine tumors value the most? Because at the end of the day, that's what we want to know, because that's how we should be basing our ideas in terms of what treatment comes next, and ultimately, in my opinion, how we approve treatments going forward. So we ended up performing a study of 60 patients with neuroendocrine tumors that were about to start a new medical treatment. The reason why we wanted to do that, especially at a time when you start a new treatment, is that's when you have to make a decision, right? And that's really when you're going to think about what is truly, truly important to you when you're making that decision. So patients then completed 4 different surveys about their goals of treatment, as well as health-related outcomes. And these had to do, I would say, with a lot of questions, which I'll show you in a little bit, regarding what is the value in terms of quality versus quantity of life. So one of the first questions that we asked was, we gave you 4 choices, and we specifically said, what is the health outcome that is most important to you? And I'll show you kind of what we saw. So 47% of patients specifically said that maintaining independence was the most important health outcome to them. 30% of patients said that keeping you alive was the most important outcome. And then 12% of patients each, respectively, said reducing or eliminating pain was the most important outcome, or reducing or eliminating dizziness, fatigue, or shortness of breath. What this really highlights is that 70% of patients actually chose an outcome that was not survival as the most important criteria in terms of what was most important when they're about to make a crucial treatment decision going forward. This is absolutely valuable because if the FDA, along with others, including our industry partners, that are looking at survival as the primary outcome for every single trial that we do in the United States, it begs the question, is that really the most important outcome if the patients that we're treating are not telling us that? So we also wanted to dig a little bit deeper into that in terms of looking at quality of life. We know that quality of life is very important, particularly in the setting when you don't have necessarily a curable cancer. So this is something that you're going to be living with on a day-to-day basis. And as a result of that, we always try to gauge in terms of, is there an emphasis that you put into in terms of obtaining quality of life now, or are you trying to really maximize that quality of life later on? And this has been looked at a little bit in other oncology studies. And one of the reasons why we look at that is that, let's say if you had a very aggressive type of cancer, then sometimes for some patients, they might say, hey, if I get a harsh chemotherapy, maybe my quality of life will diminish during that time that I'm getting the treatment, but if I'm able to control that cancer, then long term, I might get a benefit later on in terms of improving my quality of life. So we wanted to address that question and ask that question for our neuroendocrine tumor patients as well, because as we've highlighted, and as you've heard from the other experts today, that sometimes we might just watch the disease, right, and not do anything in the very beginning, because we're valuing some of these things. So if we look at, kind of quality of life now versus later, and we ask the question, do you value the most your quality of life essentially 1 year from now or right now? What you see here is that there's pretty much an even split, okay, between that. And then we ask, do you really value kind of your quality of life 5 years from now versus now? And what you still see is that it's relatively an even split. So I think what this tells us is that for patients with neuroendocrine cancers, that quality of life is actually very, very important. And that we're not necessarily willing to, I would say, sacrifice that up front for potentially a delayed gratification later on. That for our patients that we're treating, we're really valuing this on all multiple levels, including now as well as in the future. So then we ask this idea in terms of attitude, and these are, kind of some additional questions because we wanted to get a sense of, when we prioritize the different outcomes, and we found that, patients were really valuing other things besides survival. Well, what is their overall attitude on a lot of these things? So one of the questions that we asked is it more important to me to maintain my thinking ability than live as long as possible? And you can see that overwhelming majority of patients, 50 out of the 60 patients, or 83% of patients, said that that's absolutely true. And then when we asked, I'm willing to have side effects right now if it means that I could have a better quality of life in the future. And interestingly, 93% of patients, said that. So this says a little bit different compared to what we showed before, that under certain circumstances, we're willing to make that trade-off in that context. And then we asked the question, are you willing to actually put up with more doctor's visits and dietary restrictions now if it means that in the future you're less likely to develop a new disease? And that was very important to patients as well. They're willing to make those efforts to continue to see their providers if it means that there might be value in that going forward. So we really ask, kind of patients then to get a sense of, how they felt their perspectives were compared to the providers that were providing the care for them. And I think this is very important because as we've heard, again, from various different types of experts, it's really important that we think about how you build trust in that relationship between a provider as well as a patient. I always tell my patients when they come to see me for a consultation that, sometimes I might not be the right physician for you. You kind of get a sense of that whenever you're talking to the patient. The patient's goals really have to align also with the physician's goals for the patient. And there ultimately has to be this trusting relationship. If there is doubt in that trust, then in my opinion, it's not the right relationship. And that's not wrong in terms of, there's nothing wrong about that from a patient perspective. There's absolutely nothing about that from a provider perspective because we have a lot of different opinions. So we wanted to ask this question to patients in terms of what did they feel was their kind of primary goals of treatment. Whether it's to lessen my suffering as much as possible, for me or my family to be able to keep on going and hoping for more better outcomes, to make sure I have everything done to extend my life as long as possible, as well as to cure my cancer. And then we asked our patients, what they thought was their physician's primary goal regarding some of these questions as well. And what we really wanted to test was that, is there a congruence, right? Because if there's not necessarily a congruence, then we might have some issues that we have to deal with. And what we found, disappointingly, is that only 50% or about 50% of patients believe that they or their physician really had the same primary goal. So this tells me that there is a disconnect. We're not doing a good enough job on both sides, whether it's patients being honest with us, providers being honest with you guys on a daily level. And how are we able to really be able to recommend and do what's right for you in terms of suggesting the right treatment for you if we're not necessarily on the same page, right? So I think there's a lot that we have to do to improve upon this and really make this better going forward. So I think in summary, what you have to get is that patient preferences need to be considered when we're deciding a new treatment. That there are significant side effects that may not be worth the increase in survival that we have seen from other trials that have been done that led to the approvals for the treatments that we have. That ultimately symptom control might not be the same as maintaining independence, right? Independence is a capture of the underlying disease, the diagnosis itself, but also how you're able to potentially tolerate treatment. That both current as well as future quality of life are important to our patients, and that patients and physicians need to be on the same page in terms of treatment goals. So where do we go, moving forward, and how do we apply this in terms of the real world and on our future clinical trials? Well, certainly patients with neuroendocrine tumors have shown that they value quality of life, but clinical trials often don't emphasize this. The primary focus, as I've stated before, is survival. And quality of life, while it's a secondary endpoint, to me, by being a secondary endpoint, this is a secondary consideration. It's not a primary consideration. Treatments that are deemed safe may not provide an acceptable quality of life. I've heard from many of you when I personally recommended a treatment, you didn't tolerate it, and no matter what I said, you stopped it because it did not align with your goal and what you found was acceptable in terms of your quality of life. And that all of the currently approved systemic treatments that we have, while they didn't necessarily worsen quality of life, or they potentially actually helped to delay time to deterioration, a lot of times they were compared to essentially controls. So that they were compared to like a placebo arm that was done. And this is problematic because then we're not able to compare treatments to be able to decide what's the better treatment. So cross-trial comparisons have really limited our analysis. And a lot of times, even when we try to compare across trials, all of them essentially use different measures of quality of life, So then you can't even necessarily directly compare them. So we absolutely have no data on this at this moment in time. So ultimately, in my opinion, quality of life needs to be a bigger focus for upcoming clinical trials. And I always say the patient voice has a lot to do with this. You guys have representation in terms of designated patient advocacy on NCI selected trials or National Cancer Institute trials. Well, tell them what this means and everything to you and everything. And make it a priority to the FDA. And maybe you're able to potentially change the landscape for everyone to come in the future. So in summary, net patients value both survival as well as quality of life, both present as well as the future. There is a patient-physician communication disconnect regarding goals of treatment. Decision-making should be a cooperative process, and we need to have that trusting relationship with each other moving forward. And ultimately, clinical trials need to incorporate patient-reported outcomes and quality of life in order to ultimately better serve all of you in the patient population. So with that, I'll end here, and thank you so much, and look forward to the question and answer session.
I love that passion. Thank you so much. What a great morning it's been.